Good afternoon, everybody. Welcome to SEVA VentRounds. Today's October 3rd, 2023, and we're going to see a common breath sequence. And the question is more or less support. Disclosures, there's no endorsement of any mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. The host for VentRounds is myself, Eduardo Mireles, and Rob Chatburn. And I see Rob on the line. I presume you have your camera off, Rob, because of all the problems with connectivity. Is that correct?
Correct.
Yep. All right. A couple of ground rules. Keep your microphone muted. Just for the recording, it makes it nicer to go with it muted. However, if you have something to comment, either write it on the chat or unmute yourself at the moment when you want to comment on this. There are CMEs and CRCEs for everybody. Just if you're a respiratory therapist on the chat, please put your name so that we can verify attendance, and then there's going to be a link for a meeting for a survey that you have to do, and that then you get your CRC and everybody's happy. All right. So for this, we usually do not have videos here, but I thought that it would be better to watch the video that we got from Nick Fletcher, Pulmonary Toilet, but now I see that your last name Nick has changed to Gioni, but it's okay. So let's, but I put here courtesy of you that this came from X or X Twitter, X whatever you want to say it, and we're gonna take a look at the sequence, and it's a very nice sequence, and we're gonna do the exercise. I have taken screenshots so that we can analyze them later, but in general, it's a we're going to analyze, as we usually do, going through the tag, the load, and then the PV discordance. And now, because this is a sequence, you will have to come to terms on what you're seeing, and that's more related to the reality. So now that I have said it, let's show it. Moment of truth. And I guess if this is one of those breath sequences that if you can read every single one of the patient interactions that occur through this, you're ready for practice anywhere, because it has every single one available in humankind. All right. And that's the end of the sequence, I believe. Yes. There you go. I'm going to pause it. So, ta-da. So there's a lot to digest through this ventilator sequence, and I presume that many of you recognize what type of breath sequence is occurring on this patient, and so perhaps we can start by if anybody recognizes what's the breath sequence that we're seeing here, what's happening on this patient. And you can put it on the chat. That's the easiest pathway to happiness. And put your thoughts. That's wonderful. That's like actually those are the ones that I really enjoy the most, is when you are walking in through the room, and that's how they got these sequences. You're walking through and you turn around and see something happening, and you take a picture. And so what you're seeing is a breath sequence that is consistent. And somebody has called it. This looks like Cheyne Stokes. So let's just analyze. Let's go through the sequence little by little. So let's start with the tag. What do the team think is the tag? What mode are we using here? And so. Yeah, thank you, Mohammed. So rapidly, this is just pressure control, CMB, and this is important for us to recognize. This is pressure control. So in this ventilator, which is a Servo U, what you see is it will change colors whenever the breath is triggered by the patient, or the machine thinks that it's a patient signal. And you can see on these two, both on the pressure and the flow waveform, that there's no change in color. So that means that these are mandatory breaths. And at least on these breath sequence that we see here, we can confidently say that these are mandatory breaths because they're triggered by the ventilator. No, and they are the same length, so it's the same I time. And it's S for set point because whoever set this ventilator sets the amount of pressure above the PEEP. They set the PEEP, they set the respiratory rate, and they set the I time too. So this is set point, meaning that you set all, the ventilator has no extra intelligence added there. Rob, comment?
Oh, looks good.
All righty. So we're controlling pressure through the breath. Now, the next question for the teams and is what is the load? Watching these two breaths that we have here, what is the load that you see? Pay attention. In these two waveforms that we have currently, so there's a couple of hints that you may recognize. First one, we don't see the any patient muscle activity, at least on the triggering, either in the PMOS or on the in the pressure or on the flow waveform. And then the pressure peaks and then it decays very slowly during the inspiratory time. And between these two waveforms, they actually look very similar. There's no difference between these two. So during the I time seems to be around 1 second, and this doesn't decay. So this is very suggestive that during inspiration, the load is actually resistive. Now you could say, well, Eduardo, could this be PMOS? Could this be the patient doing effort? And there's a couple of hints, and you'll see it on the next sequence, how the waveform for PMOS will modify. But because these two are identical, unless the PMOS was identical, that goes with it. But then you'll see the expiratory time, and it takes for the patient, the peak flow is blunted, and it takes several seconds for it to reach baseline with a concave form. So this looks like resistance. Rob?
Yeah, two things. One, because these two breaths were machine triggered, there's no PMUS at the beginning. And if there was PMUS somewhere after the start of inspiration, you would not see a smooth decay in the flow. You'd see a distortion in the flow. The other thing is, it looks to me, if you look at the volume waveform, it looks to me like the inspiratory time constant is shorter than the expiratory time constant. It could be, it could be a wave collapse.
Well, yeah, I guess so. This is the peak flow, and then the decay. I mean, the decay looks very slow on the flow waveform, Rob.
I'm just looking at the volume waveform. The volume waveform also reflects the time constant. And if you turn the inspiratory volume curve upside down, that's what the expiratory curve should look like.
Mm.
So you see what I'm saying? It's harder to see in the flow waveform.
Yeah. But we would agree that there seems to be resistive loads.
Oh yes, for sure.
So now let's go to the. So we don't see any PMOS Perhaps a little bit here, but otherwise, I don't see any evidence of PMOS during inspiration or expiration. So I would say that at this point, this patient is doing no activity, and that this looks like the patient is essentially in apnea. It's not doing any effort because I don't see any evidence of triggering or expiration. It's just a very passive set of 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 breaths. So let's move to the next one. And now let's, I'm gonna give you the tag. So the tag is gone, all right? So PCCMBS, because nothing changed. It's the same breath sequence. But now you have this breath, and then you have expiration and the next breath. So what is the, and I'm gonna ask you to focus on this breath over here, on the second breath. I'm putting a 2 over there. So what do you think is the load during inspiration on the second breath? Yeah. So that's correct, Lorenzo and Mohammed and Tim. That's great. So this is why I put this sequence here, because it becomes very evident. You have this breath here. It looks similar to the prior ones. If you see the prior one, the same, very similar. The scale changed, because remember that these ventilators adjust automatically the scale. So here the flow was at 100. On the next one was at 70. So that's why you see it a little bit higher. But look what happens with the flow, compare this flow, which was passive at that time, with this one. Again, the breath was triggered by the machine, but you see that instead of that decay, you see this now moving up. And so this is there's presence of PMOS during inspiration, and then we don't have the expiration for this. But another key feature is look at the difference between the passive and the volume during inspiration. So you see the difference because now there's presence of PMOS. And then during expiration, many of you recognize the presence of PMOS, and that's correct. Instead of the decay that we were seeing on the others, you see how it moves away from the baseline, which tells you that this patient has expiratory work. So PMOS, this one is still passive. I will just put here, there's no PMOS. Rob?
Yep, that looks good.
We're in agreement, great. And now PV discordance. So let's focus on the second breath. So how's the trigger? Is the trigger normal, early, late, false, or failed? And this I see the storm of earlys. Yes, this is an early trigger, and that's why you will see that we, in the classification, we use the term early just to describe what's happening, because if you were classifying these based on how it's named commonly on the literature, which is reverse trigger, it talks about a specific pattern, but you'll see how this transforms into something else. So the pattern that we're looking here is a mandatory breath followed by evidence of patient activity. So this is a mandatory breath. It was not triggered by the patient. And then there is evidence of PMOS. So that's the trigger. And since you saw that, whatever happened, there's going to be work shifting during inspiration. That's a normal consequence of early trigger. And there's going to be likely early cycle, which is a normal consequence of early trigger. But the one that you call and the one that you have to treat is this one over here, if this was the only pattern. But I want you to just recognize that this is an early trigger, and we recognize the presence of expiratory work, as you all did. Comments, Rob, on this one?
Oh, it looks good.
All righty. So now you have recognized very nicely expiratory work and an early trigger. Okay? So here comes the next set of breaths. So now you're seeing more PMOS. All right. So I'm going to give you the tag PCCMBS. All right. Nothing has changed. It's still the same mode that Nick had. And then you have the first breath that actually ends in 2 breaths. And then you have the second breath. So let's start by the first breath. And I will give you just for given that during inspiration and expiration, there is pure PMOS, okay? Just for the sake of, instead of having a nice decay, instead of having something that looked like this and something that looked like that, you have all this activity in which the patient is inhaling and it's exhaling actively, all right? So for the first breath, what's the trigger abnormality that you see? Yeah, good. The early trigger is starting to come out. So I'm gonna put here a 1. And this is a yeah, perfect, Nick and Lawrence. So you see a mandatory breath followed by patient activity by PMOS. And we know it's mandatory because this is a flow trigger breath, the second one, and there's no change in color here. So now you can say, definitely this is an early trigger. And in this case, again, for breath number 1, you're gonna see work shifting, and you see early cycle, all right? And that early cycle led to a double or multiple trigger. This is a classic pattern. So that's why you see that we do not classify double trigger as a type of asynchrony or synchrony or discordance, because there's multiple causes for double trigger. This is one of them. So now you have recognized early trigger as a cause of double trigger, and as we discussed, there's work, expiratory work. So now let's talk about breath number 2. What do you see on breath number 2? What about the trigger? Is it normal, early, late, false, or failed? Yeah, and this is this is of all there's many gaps there that exist right now on the taxonomy and how to classify things. But many of you I mean, the fact is that you're recognizing that there's a major drop in pressure that this patient is generating. Actually, look at the amount of drop that the patient generated on the prior one. I mean, it went below -3. And so this patient generated a lot of inspiratory effort rapidly. It went from exhalation to inspiration very rapidly, and it generated a drop. And the ventilator tried to pressurize. It triggered, actually, if you notice, it triggered from down here. The machine detected the changing flow, and it triggered as early as it could because it's flow triggered. But you have this drop in pressure because I think the magnitude of the PMOS is larger than what the ventilator can pressurize as fast as it can. So in my booklet, these probably would be a normal trigger, although I could imagine that the work of breathing for triggering is high on this patient, and so I could be argued against in this, but I would say that the ventilator is trying to trigger as fast as it can. It's pressurizing the moment that it could, but the patient is doing a lot of effort. Rob?
I agree. I have on simulations set the trigger perfectly and then made large inspiratory, expiratory efforts like that, and you still see that. It's just the limitation of the ventilator, like you said.
Yeah, and so, but I love the fact that you guys are thinking that this is late, because that's how a late trigger would look. And so if you see this, your job would be to say, is the threshold set appropriately, and if it's not set appropriately, then set it appropriately to try to decrease the drop in pressure as much as we can. All right, and so after that, the patient does a lot of effort. So you see the work shifting. So for breath 1 and breath 2, a lot of work shifting. Instead of being this nice decay, all of this is PMOS. The patient is generating a lot of PMOS, and then the patient, the breath cycles, and you actually can see how the patient is doing so much effort. Look how the pressure even drops after this. It goes as low as it can, and you don't see that. You can see a little bit of deviation here, but you don't see that peak that we would be expecting. And then there's the expiratory work. So these led to, again, a little bit of of early cycle and that's why you see that drop, that massive drop in the pressure, is because the patient was continuing to do a very high effort. And so these two drops in pressure are a manifestation of a very high PMOS. So if I would draw PMOS as a bar, it probably started here and ends around here. It's a very long period of PMOS, and the ventilator is tried to pressurize, and then the patient switched to expiration. Rob?
Yeah, I agree. That's all good.
That's good. So now you have here, you have recognized a normal trigger. We talked about a late trigger and how it could, I mean, it's challenging, and this is a matter of if you see it, you're going to have to put it and decide if it's a ventilator performance or not. We showed work shifting, how it looks on pressure support. We saw a double trigger and 2 early cycles on expiratory work. Now, the next one. Now, this one, now you have several breaths here. You have 4 breaths in this sequence. So before we only had a couple. All right. So now I'm going to give you the tag PC CMBS. The load, we will agree that it's all PMOS. I mean, these sine waves that you see here up and down is how it would look if you were breathing normally. I mean, that's how the sine wave looks, PMOS. Internal screaming, yeah, Mike. PMOS. So now, if you look at this in terms of the trigger, there you go. So now you're starting to see that the PMOS during inspiration, I mean, the effort of the patient, and I want you to recognize that, is that this is similar to the prior one, in which is a normal trigger, right? So, but you can see the amount of effort that it's being generated by the patient is actually increasing in depth from one to the other. You can see how from 1 to 2 to 3, it's actually dropping even below the second baseline that it's over here. So the patient is doing more and more effort, as you can see this. Yes, Mike, this is the same patient. It's a sequence. And so now during inspiration, we talk about that this patient is probably, you actually look at this, the scale has changed, but look at the pressure that the patient, the machine is pressurizing right here. And the patient, the PEEP, look at the PEEP, how it has gone up on this one, and it's because the patient is actively exhaling, and so the pressure goes up because the patient is exhaling actively against the ventilator. So the patient is breathing in really hard and now actively exhaling against the machine. So that's why the pressure is higher than what probably the set PEEP is. So there is high amount of expiratory work, high amount of inspiratory work. And I would say, Rob, and I would like to hear your comments here. You can see the tidal volume here, it's at 1600. And so I would say that this patient is under severe work shifting. And then the cycle, you can see compared to the other one, how now the cycle is starting to become better on this patient, and perhaps even a little bit late on the last one. So you see how the pressure during expiration starts going higher. I don't see a real gap here, but probably it's starting to become a late cycle as you get to breath number 3 and 4. Roberto, what do you think?
Yeah, I would say it's definitely a late cycle. Otherwise, the pressure wouldn't go up.
Yeah.
The pressure goes up because it sees the patient starting to exhale or the PMUS starting to relax. So if it was a perfect controller, it would just let the patient exhale, but it's not. So that's a late cycle on, I would call it a late cycle on every one of those. The other thing is, I think you've just identified a new form of synchrony problem. It's where you had that, where you showed that the PEEP, the applied PEEP, is actually higher than the set PEEP. And it's also higher than the auto PEEP. It's higher than the total PEEP. So you have what we might call an inadvertent PEEP or something like that, but it happens externally, not internally. So it's like auto PEEP that's happening in the patient circuit, not just in the lungs. So we need to come up with a new name for that.
We can call it the pulmonary toilet type of PEEP, since they share this.
We'll call it the Mireles effect.
Nick's PEEP. There you go, Nick.
Nick speed, there we go.
PMOS increases with set P band. So yes, sounds. Oh well. Wait, Addy. There's more here. It's coming. It's coming. Wait, there's more, Addy. So now you have, just for review for everybody. So we have seen the normal trigger, but with high work of PMOS, severe work shifting on all the breaths. Now you see late cycle because the patient's neural time is becoming shorter, and a high amount of expiratory work, even causing the expiratory, the PEEP, the pressure, the expiratory pressure to go up. And then comes this. So now, and these are all sequential. I'll put the sequence at the end for all of you to see it. So again, you see PC, CMB, S, and then during inspiration, we still have PMOS on both of them. And during expiration, you still have evidence of PMOS. And during inspiration, now you have again a normal trigger, but with less depth, right? It's less effort than before for breath number 1. For breath number 2, the trigger, it's again, the pattern is mandatory followed by PMOS. So that means that the breath number 2 is an early trigger. So you see that again here. So 2 and 1. During inspiration, we see work shifting for both breaths. And then now we see again that early cycle in which there's amputation of the peak flow. So we again see the early cycle, and on one of them, on the second one, again it creates that double trigger. But I wanted to show you something that it's actually kind of sweet here, which is if you notice in the second effort that the patient does, the patient PMOS starts probably around here, and it keeps going, and and it triggers another breath, okay? But then after it triggers the other breath, it goes passive and it starts decaying exponentially, this is just the PMOS essentially ended over here. So the patient effort became a little bit shorter. It's not as long as on the prior one that we saw. And expiratory work. Can you explain the exponential rise in flow in the second breath? Exponential rise in flow. This one over here, Emil? So there's a question, the first breath. Oh, so why does in the first breath, why does this rise like this? Well, that's the presence of PMOS. So whenever you have PMOS, you're gonna see.
Sorry, Eduardo.
Yes.
So it's the double triggered breath. So notice, yeah, the double triggered breath, the first one, not the double trigger. So notice how the flow actually seems to peak, but then continues to rise beyond that.
Yes, so that's the presence of PMOS.
Yeah, so is there PMOS that is expiratory at the very beginning of the breath? Is that what we're looking at?
So you mean what it raised over here, and you're asking why this period over here that I'm circling, correct? Yep. Yeah.
So why is there a rise right after the initial portion of the breath?
Yes, because the initial part was the mechanical breath, so it was the manifestation of the machine delivered breath, and then the PMOS activated very close to the as it was ending, and then the patient started adding to that P vent the PMOS from the patient. So you have P vent at the beginning, and then you have P vent plus PMOS afterwards. So this is right here, this little period of time that I'm putting a box in, it's only P vent. And then you see it rise further because it's now P vent plus PMOS. That's the reason why you see the flow increase even. And it's actually, it looks exponential, but it's sinusoidal. And so just similar to the others in which it's doing effort up and then it starts decaying. and triggers the other breath, and then it goes quiet and the patient exhales. Rob?
Excellent. Thank you so much.
Yeah, that's exactly right. It's exponential because PMUS is roughly exponential.
Excellent. And then the patient goes quiescent again, and so goes into so it's PC CMBS again. We have a early trigger on this one. This is a machine breath. You see that it's not triggered by the patient. So this is machine, and then you see evidence of PMOS again with that the flow increasing instead of decreasing. Just compare. This is passive. This is not passive. So that's everything that is moving away from the baseline is PMOS. So this is another example of early trigger. So one, that's an early trigger. The second is a passive breath completely. Again, it goes into that passive with a little bit of activation of the expiratory muscles. So that's it. So this is the sequence that you see over here. And so I'm going to play it again, and we'll talk about it. So I know that many of you came out later, but look at the sequence now and how it's passive, there's expiratory muscle, and then early trigger, expiratory muscle, early trigger with early cycle double trigger, expiratory activity. Now there is a early cycle, and then it starts really high work of breathing of this patient with late cycles there. The same, a lot higher frequency, higher depth of the breath, putting in 1600 per breath. It goes for an amount of time. It starts slowing down, becoming again the I time a little bit, the inspiratory time from the patient longer. And then it starts slowing down. The intensity goes down. There's an early trigger. Another early trigger. It starts relaxing. And there goes into apnea. And continues in apnea. And the tidal volume goes down again. And it starts again. So, whew, yes, Mike, that's correct. That's Cheyne Stokes breathing seen from a ventilator standpoint while you are on PCCMB. But I thought that this was, and that's why I put it here, because this was just a fantastic example of every single synchrony problem that you can have on a ventilator. So now the question, and I will open this to the universe, is how do you deal with somebody with Cheyne Stokes on the ventilator? They're going to have periods of high work of breathing, and they're going to have periods of apnea, and that can lead to what do I use, right? So there at some times the patient is going to get 1600. At some points they're going to be getting 300, and they go back and forth. So I'll open it to the chat to see what people put in. How would they manage this? So I'm seeing some comments come out. So the first one that came out was auto mode. So if we place this patient on auto mode, when the patient goes into apnea, then the mandatory breaths would come in. When the patient starts breathing on its own, we can set up the mandatory breaths get turned off, and then you can set the amount of pressure support. So you could essentially put it out of it with very little support. So the question Rob asked is what type of auto mode? There's 3 types. So there's PC to PS, so pressure control to pressure support. There is PRVC to volume support, and there's volume control to volume support. And I would probably, since these are going so fast, that probably I would say that pressure control to pressure support with pressure support of very small. Let's see, there's another option that says PRVC and RSAL. The challenge with PRVC on this is that the ventilator would decrease that if your goal was to keep the tidal volume at the same level the ventilator will be dropping the amount of support and then increasing the amount of support. So in a way, it's a poor man's ASB for this mode. So that would be an interesting alternative to use something like that, in which you, when the patient starts asking for much, the ventilator decreases support. When it stops doing it, it increases support, and that way try to do a mode that was used in the past to deal with this, which was called ASB, but not the ASB on the ventilators, but the adaptive servo ventilation on the non-invasive world. There is another question here for NAVA, and NAVA may be, I don't know if NAVA would completely suppress this. I don't know. I know that we do that for periodic breathing from over assistance, but I don't know if with Cheyne Stokes from brain injury or from heart failure, would it just behave the same way as such? Rob, thoughts?
The problem with NAVA is when they go apneic, you'll get an alarm.
Yeah.
And that won't happen in auto mode.
So, yeah, I mean, there's a good, yes, Mohammed, we need to treat the main cause, which is of the Cheyne Stokes breathing, if it's treatable, and sometimes it's severe heart failure or brain injury, and there's no good option for this. Just recognizing it. I mean, this patient is still on a high FiO2, which I presume is from some other sort of injury, or perhaps heart failure or pulmonary edema. I don't know. Heart failure in this case, ejection fraction of 10%. So yeah, that's and we know that from this actually the presence of Cheyne Stokes ventilation in patients with heart failure has a poor prognostic factor, just because it's a manifestation of how poor is the ejection fraction and the circulation, and with the respiratory controllers. Yeah, so absolutely. And Lorenzo talks again about the non-invasive with servo, so ASB. Although I would say, and I don't treat this anymore on the outpatient, but I believe ASB, they put like if you had a low ejection fraction, it has a black box warning because of the servo HF or severe HF trial that showed increased mortality, I think. But yeah, that's I mean, it's one of the alternatives to use ASB. Yeah, it's contraindicated if you're low EF. Yeah, but very good point. So in general, I would say we learned a lot. I don't have a perfect answer for this. How do you treat on a mechanical ventilator a patient with Cheyne Stokes? But I would say that in general, this would be a great discussion or article on what would be the best mode for somebody with this. And I think that perhaps auto mode with PC pressure support, or some algorithm that it's fast at responding for PRBC or volume support may make sense. But yeah, let's discuss this further. So now this is the CME for all those RTs. Please put this, take a picture or scan it, so you get your CRCEs. For the staff here at the clinic, here's the code. And now Ryan just put in the forms for that you can click on the chat if you are a respiratory therapist, so you can get that. Again, send us via Twitter or through email your waveforms. We would love to see more, and all of these are recorded and we put them on YouTube. We are at episode 58, I believe, and we'll continue to do so as long as we have ventilators and patients. Thank you very much to everybody. This was a great session, and again, Nick, this was a fantastic sequence that you cut, so we really appreciate it, and thank you all for being part of this learning episode. Have a great day.